All right, on to you.
Thank you, Alex, very much. Welcome, everyone. We are so happy to host you today. I'm Kelly McClendon from CompliancePro Solutions, and we're going to talk about the OIG information blocking CMP civil monetary penalty final rule came out in June. We're going to talk a little more than just about that rule itself, but we are going to try to give you some clarity on the rule, but we'll be doing some more general Cures Act information as well. Again, typically centering around information blocking this time. My great friend and peer who I have worked with for so long, Rita Bowen, is joining me today, and I couldn't be happier to have her here. She's also very much of an expert, works for MRO, but as you all know, has worked for many, many years in the profession, especially in the release of information world, and she understands HIPAA and Cures Act inside out. And we're trying very hard to marry those two together as the rules really require. But all of us, including yourselves that are listening, are learning. So, so happy to have Rita here with me, and she'll pick up later in the presentation at a certain slide. Let me make sure I have everything go here for my slides. There we go. Here's our agenda. We've got a new sheriff's in town. There's a couple enforcement hammers, some practical Cures Act in a graphic that I created. OIG information blocking civil monetary penalties. We'll talk about that, of course. Then we'll talk some more about information blocking exceptions. And we've got a checklist, and at the end of the presentation, there are some references. So, new sheriff in town for information blocking. So we've got both the OIG, the Health and Human Services Office of the Inspector General, who has the authority to investigate and assign civil monetary penalties under the information blocking rules. ONC, the Office of the National Coordinator of Healthcare IT, that's the agency you most know because they did meaningful use back 10 years ago and all to get the EHRs together. They do the certification of EHRs, and that is very important stuff. They also really originated the whole Cures Act rule. They're also there to provide subject matter expertise, and they're going to soon release what they call appropriate disincentives for providers of care. Now, the rule we're talking about today came from OIG, and it's about civil monetary penalties. And we're going to tell you who they apply to because it isn't everyone. But the appropriate disincentives that are supposed to be published this fall, they will come from ONC. And within this final rule about CMPs that OIG issued, they say plainly they're going to be looking for subject matter expertise to both ONC. And so we've got these two new sheriffs now. We've known about ONC in the past, but for information blocking, these two agencies, and then of course, OCR, the Office for Civil Rights, because they also say in these penalty rule that if they need to reach out to the Office for Civil Rights, either for some investigations or subject matter expertise, they'll do that as well. And OCR, of course, has vast experience in HIPAA, but again, not so much in the Cures Act. But OCR, don't be confused, is not going to enforce the Cures Act. They just enforce HIPAA, but because they're so intertwined, you have to be careful. If one gets involved, the other may. So the enforcement hammer, how about $1 million per violation? Does that get your attention? Well, it's actually for any actor that is subject to these civil monetary penalties, or CMPs, as we'll call it, and they call it. And it really isn't for just the Joe average provider of care. So the $1 million per is more specific in what it applies to. And we're going to talk about it in the slides. But it is an attention getter, and that's for sure. So anytime you start having an enforcement hammer this big, and it's $1 million per violation, oh yeah, we can stack violations. So it could quickly become a multi-million-dollar enforcement issue. But that is, in fact, for particularly egregious conduct, and we'll talk about that. So again, today's presentation, let's get you clarity on this new final rule, which is confusing in who it covers, but also some more information about the Cures Act in general. Let's start. What's the Cures Act? Well, really, payers and providers, and there's two rules, ONC and CMS rules work together, so it covers payers and providers. They're going to have to grant patients and other third parties access to their electronic health records without delay or expense. And it's intended to really provide a greater level of access to the information to help with coordination of care between provider organizations, let's say, drive population health analytics, make advances in medical science, help patient care and patient safety. Very, very lofty goals. The idea, many of you are record managers and you understand this, is that more access to the actual information itself is good for patient safety and care and things like analytics. Of course, the downside is now you're going to have more information out there. According to ONC, the Office of National Coordinator of Healthcare IT, the Cures Act prevents HIPAA from being a barrier. They say that. Now, we've been hearing that for years and years, that HIPAA is inappropriate applied. It is a barrier to exchanging information. We can't get done what we need with HIEs and such because HIPAA's in the way. So now they've put out the Cures Act, which really counterbalances HIPAA. Maybe that's the right way to say it, and opens up the flow of information much more without removing any HIPAA protections. Well, gee, how the heck are you going to do that? Well, that's part of what we'll talk about. They're going to really simplify patients' access to their medical data, and it prevents what they call information blocking, where the patient or other third party is not getting the information that they requested. It opens the doors, and the Cures Act does this on purpose, to non-HIPAA applications. So applications, maybe health apps and things that might be on a phone or other medical device that really are not under HIPAA and not sanctioned maybe, or they're sanctioned maybe not by the EHR vendors, but they are not HIPAA-based applications. They do not have the HIPAA rules apply to them. The data from the patient, those different applications are going to be able to go request the patient data and bring it in, and HIPAA isn't going to cover those devices. To some degree, the Cures Act does, but it's not a privacy and security rule. So it's really, we've now are opening the door to get outside of protected health information living only in the HIPAA universe. Now it's electronic health information that lives in a wider Cures Act universe. And of course, they have to put enforcement out there because we've been implementing Cures Act for a number of years, and it's extremely sporadic. Don't feel bad if your organization hasn't done a lot or you don't really know what you're doing. Some are very far ahead, depends a lot on their EHR vendors, and some have not really even hardly started. That's typical in the industry, but now enforcement is coming for different areas within the rules, so it's going to be important to be moving on implementation as soon as you can. But again, for providers specifically, they're going to issue appropriate disincentives for healthcare providers supposedly this fall. We don't know what those are. Are they money penalties? Are they, we don't know what they are, but we know there's more enforcement rules coming. And if you're a provider of care, they will for sure sweep you up. With the rules we have now and the enforcement we're going to talk about today under the CMP, they may sweep you up as a provider, but with the appropriate disincentives, they will sweep you up with penalties or enforcement activity. So anyway, we're waiting on those rules this fall. I took this slide, and as I always do with my presentations, I want you to have copies. I want you to be able to take pieces and parts and possibly slides and use them to illustrate concepts, or if you're making reports to management, things like that, perhaps support your positions. What this slide is intended for is in general illustrating a little bit about how the Cures Act works with interoperability. And within interoperability, what you're really doing here is, if you look to the left, you have a smartphone with a health app. Then you have a dark blue bar, which is an EHR. It's a FHIR-based request over to an EHR, possibly other systems. In a certain format, you're asking for patient information. The EHR will go back and forth with that app using protocols that are listed as security ops, smart FHIR, APIs, OAuth 2s, using those protocols to identify the patient, although I'll throw in here, you still need clean MPIs, or this is going to be a mess. Identify the patient, get the security part of the equation of this interface back and forth happens, and then eventually the EHR composes and exports the electronic health information the EHI asked for by that device. That's what that graphic is showing. What I'm saying over to the right-hand side is what you're not hearing much about, and that is there are compliance requirements from the privacy officer and maybe compliance areas for the reviews of these FHIR type transactions. So there are, in fact, quite a few compliance steps that very few organizations have really pinned all of that down. They're concentrating on getting their interfaces established, understanding when to apply an information blocking exception perhaps, but as far as all of the elements of compliance, that's really still being developed as far as good practices or best practices in the industry. So this slide's a generalist slide, maybe something helps you to understand. And again, I'm certainly happy to individually talk you through this stuff another time. Who's enforcing information blocking? Well, it could be ONC or OCR doing individualized education on the rules, creating corrective action plans if there's been information blocking. Although, again, OCR is not the primary enforcer here, but they can be called in if, let's say, for example, information is being blocked from a patient getting access to their own information. Well, that's going to be a patient access rule violation under HIPAA, but also an information blocking violation under the ONC rules. So who's enforcing? Well, it could be both of those agencies in certain use cases. OIG, Office Inspector General, may refer matters to ONC or OCR, but OIG, again, is kind of limited to the civil monetary penalties. But again, they're going to be referring to the other agencies. And you know, the real reason that I made this slide is to show you they plainly state, and they mostly being the Office National Coordinator of Healthcare IT, but also OIG, they don't really understand all the consequences of these rules yet. They're learning as they go. And they're going to involve different agencies, the three that they can, depending on the case facts. So if you get an investigation under ONC, it still could end up being HIPAA. And if you get a HIPAA violation under OCR, it still could be referred over the Office National Coordinator for Information Blocking enforcement. So that's the whole purpose of the slide. that, oh my goodness, they can bring in the other agencies. We don't like that because we will be confused and we will be worried that you've got different investigators with different styles doing different things with a single case. So could be very interesting going forward with enforcement. Let's talk specifically about this June 2023 enforcement civil monetary penalty rule. It's effective September 1 means it's already in effect. It's civil monetary penalties for information blocking that only applies to actors defined as health IT developers of certified health IT that's actually offering their EHRs to others, which we know some of the vendors do that. They will offer the EHRs from large customers to small customers, and that is covered by this rule. Health information networks and health information exchanges, those are also covered under this rule. And that's where it starts to be complicated. What if you're a provider of care and you're also an HIN or you're also an HIE? Then these rules may very well apply to you. So it is not clear cut when providers might be held liable under the information blocking rules in today's world with the civil monetary penalties, much less the appropriate disincentives that are going to come. So basically what they're saying is that as they laid out the ONC rules under CFR 1003 subpart N and 45 CFR 171, they always knew they would work with OIG on the penalties. That's a part of the rule. So that was built to work together. You actually have a complaint portal now with OIG and ONC. Either way, people can report to either of those two agencies when they think they've had information blocking. So again, it's very important to understand these agencies working together are going to make it much harder in the investigations world because you may have two investigators, three, who knows, it's complicated. So the violations, again, are set for entities offering certified health IT. They didn't explain it very well, but it seems as if, let's say, one entity is offering to share their EHR with another. They can't turn off that capability later and block the information from going, let's say, from the larger to the smaller site. That would be the type of violation that possibly could be considered for one of these $1 million penalties. You got HIEs and HINs, they have administrations and networks. Those organizations are subject to these fines. But what if you're a provider of care, not just participating, but that you own it, that you're considered an HIN? Then does that mean that you're subject to these penalties? We've seen no examples. It's hard to say, but we think you probably are. They will, when they are considering the penalties, look for the nature and the extent of the information blocking, the harm resulting from the information blocking, how many patients, number of providers, number of days the information blocking persisted. Those are the kind of things they're going to evaluate when they're looking to affix these penalties. So it's important that these issues get resolved fast, because information blocking, if you're looking at the number of days it persisted, that's a pretty small time frame. And that means tomorrow is another day gone by that you could get held accountable for if you're information blocking. So be very careful. These things should move fast. Information blocking is defined as a practice that, except as required by law, which is a big deal, or specified by the secretary, is likely to interfere, prevent, material, discourage access, exchange, use of electronic health information. That's the Cures Act definition of what we know as protected health information under HIPAA. That's your base definition. So any practice, unless it's required by law, and there's maybe some number of those type practices that would not be subject to the rule, specified by the secretary or specified by a secretary, they directly come out, Secretary of HHS comes out and says, this is not information blocking practice. But otherwise, any processes that prevent or material discourage access, exchange, or use, that's information blocking. And so it's a wide definition, very hard to say exactly how it applies everywhere. But you also have to put this in. And if it's conducted by a health information technology developer, an exchange, a network, and that they know or should know the practice is likely to interfere with the access use of electronic information, or if it's conducted by a healthcare provider, the provider knows such a practice is unreasonable and likely to interfere with. These are incredibly complicated statements about that, there has to be knowledge that you're performing information blocking to get here, or you should have known. Now, should have known means the government thinks that you should have known, even if you claim that you didn't know. So it is a very complex formula to decide whether someone or not has performed an information blocking violation. Again, what I'm really showing here is the complexity that we're dealing with in these rules. So who does the civil monetary penalty OIG final rule apply to? The list of potential actors, they call them actors. That's different than what you hear under HIPAA, which doesn't use that word. Different actors, and the reason I use actors is because we may be dealing with individuals outside of HIPAA's coverage. So it could be a patient with a phone, so there's different actors, or a health app company on a phone. But if you're a public health institution, clinical data registry, public health agency, health plan, healthcare providers, so that sweeps up the payers and the providers all at once. And if you could meet the definition of HIN or HIE, then you could be subject to these penalties. So there is a little misinformation out that these penalties are nothing to worry about if you're a provider of care, because you're going to have other penalties called appropriate disincentives come down, but that's not true. Many providers in the United States already meet definitions of HINs or HIEs, and you would therefore, or they share their information systems or EHRs. So therefore, it is difficult to say who these apply to. And again, there's several levels, because just because you did it and it applies, if you didn't know that was information blocking and there's no expectation you should have known, then it wouldn't be a violation. But again, very complex. They say in the rules their enforcement budgets are not unlimited and their resources have to be marshaled and managed. But they don't have to investigate all complaints like Office for Civil Rights must for HIPAA. If you have a complaint under HIPAA, it's going to get investigated. But under OIG ONC rules, they're only going to investigate what they want that come in from complaints. That's much more like what the Federal Trade Commission does. You can complain all day long. They may or may not investigate based on it. In fact, most of the time they don't. Now, we don't know how that will work here. They could choose to investigate a large percentage of their complaints. We don't know. But they're saying, giving themselves room not to have to investigate each complaint. They're going to try to prioritize based on the complaint, not actually within CompliancePro Health. We have an information blocking application that you can use to kind of help pin some of this stuff down. But, they're going to be looking at in their complaint portal whether harm was caused, the impacted a provider's ability to provide care, lasted for a long time, was a financial loss to federal health care programs like Medicare, or was performed with actual knowledge. So they're gathering quite a bit of data about these incidents inside these complaint portals. From a compliance perspective, we could be hit with requests for information from various areas that cover these bullet points on the screen too. So you're going to have to think about how you're going to manage your compliance of those.
And hey, Kelly, this is Rita. Let me just interject that those complaint portals are already available. So you can already review those and see the summary of the type of complaints. And I would encourage you to do that, because that lets you see the eye from how things are being reported now, so you can prepare should any of those be applicable for you.
Yeah, perfect, Rita. Thank you. So those two portals are listed on our, I think, last slide, or one of the last slides back there. So you are going to get those complaints and you can go look. And then if that scares you, I know, again, we have applications that have all of those data elements that we track, because it's so complex that I think folks are going to find out it's not a privacy incident so much. It could be, but it's a little different. They're asking for a lot of different information in those portals. So, again, they can apply to health care providers now, and this is very important to understand, that you need to be evaluating what's your status as an HIN or an HIE, and are you sharing systems with another site, EHR systems, and especially if you're the larger of the EHR systems. So again, providers can in fact end up swept up under these civil monetary penalties. I went and looked up the definition of healthcare provider, because for all of these, what's an HIE, what's an HIN, all of that is listed in the rules. They've been published previously too, but they do have the technical definitions, because I think at times the attorneys are going to have to dive deep and try to be figuring out what rules apply to, what entities. And again, another slide on what does it mean to, what's an HIE and an HIN under the definitions of the rules. And again, we're running on time, but I'm not going to really get into this so much. But again, the HIE and HIN elements are something that you need to pay attention to, because it can be an HIE among two or more unaffiliated individuals, but there's ways, you have to have agreements and things like that. But treatment, payment, and operations type sending information purposes could get involved with HIE and possibly make you subject to these rules, although possibly not. We're unclear on whether the rules only apply to the Health Information Network or Health Information Exchange administrators, the owners who runs that, and how much it actually reaches down to providers that just use it. We think there's a cut there, but again, you can tell from what I'm saying, it's complicated, and that you need to be careful and probably get some guidance from legal counsel if they're knowledgeable on these rules as to when you might have them apply and not, because you do want to know whether any $1 million per violation penalties apply to you. So again, exempt from the definition, information blocking are practices required by law, but it is still, basically all types of HIPAA request or release of information type requests are covered by the information blocking rules. It's a little confusing because patient access is required by law, but it's also under HIPAA, but it is also covered by the information blocking. So just again, more clutter for us to try to wade through. And I just need to say, and Rita certainly backed me up on this, they're saying in the rules, we don't really know how this all plays out. We're just going to learn as we go, and we will evolve. And that's fine, but it is very difficult for us on the front end to understand who's in, who's out, which practices for which disclosures meet the standard and have to be information blocking. You know, most of your release information, if not all, most is going to be covered by information blocking as well. But which pieces, where is it required by law that you're exempt? That's tough to sort. If you have state laws, breach is not so much, I guess, but privacy laws and other behavioral, HIV, 42 CFR Part 2, sanctions, substance abuse, minors, all kinds of other laws that are more stringent than HIPAA, and they supersede it. Those laws still are in effect, and they can very much impact whether or not you're going to make a release. But again, say that you can't release or disclose to someone because of substance abuse, you're still obligated, if asked, to notify that which, you know, that if you have issued, let's say, a privacy exception for information blocking, that was assigned. So while those other laws are more stringent than HIPAA do apply, and you do have to follow them, you have to figure out what that means under your information blocking and invoke the correct information blocking exception depending on your situation. It's case by case. And that's what we're going to actually get down to, is case by case studying it. How long do you retain information blocking documentation, meaning compliance documentation? Well, at least 6 years. So there's no record retention requirement for information blocking documentation. And they don't really say what documents you have to keep to document when you've invoked information blocking exceptions. But if you look at it, OIG has 6 years from the date an actor committed a practice, OCR 6 years. We've got different 6-year hurdles. So I would suggest that your information blocking documentation is looking at about a 6-year retention requirement. So if you invoke an exception, you had better document it, because you're going to have to document what conditions you met, and I will show you that in a second. But you're going to keep that documentation for at least 6 years. Rita, I believe we are here now where you go.
Thank you, Kelly. I appreciate that. And as Kelly has said, there is a lot of gray area in this rule, because it's still left to be interpreted. And he suggested, as I will also, that you should involve your legal teams in the review, but they need to truly have read the rule and understand the rule. So you may even need to engage in a specialized person that has really invested in reading and understanding these rules. As you will notice, when we first started, Kelly and I have worked together for a long time as colleagues. I've used his product for years. We've spoke together in the past, and he knows very well that with HIPAA and with this rule, it really all depends on who the attorney is representing. So I would keep that in mind, is that all of this is subject to be reviewed and to be evaluated. And when you go to court, the other attorney, if they're smarter than your attorney, can possibly win, even though there may be an issue that you've tried to adhere to the rules. So on this slide, you see the connection to the rules, and I encourage you to read them. They are not an easy read. but you really need to understand this world of information blocking. So Kelly will go to the next slide. There are 8 exceptions that have been documented for information blocking. The first 5 in that lighter blue are really applicable to the person in the facility that has to document and when they're responding to or not responding to a request for electronic access. The darker blue exceptions really involve the access, and it's usually those are controlled by the vendor. So we're really going to concentrate on these first 5. Next slide. So as I said, the first 5 that we really need to focus to is the preventing harm exception. You have to be aware that, and we have now given physicians and others that are documenting the records the ability to highlight if they don't want the information to go to the portal immediately. So they're saying that could cause harm if they see that before we get to talk to the patient. So if that exception has been applied, when does that exception end? That is something you need to think about. Is it just that it's not going to flow to the portal immediately? Or is it going to hold forever? And if it's holding forever, how do you tie that back into the general release of information that you may receive a request for with an authorization? So you have to look at all those together. And as Kelly said, the typical privacy and security exceptions will be applicable here. And in those, you have to know what's specific to your state. Specifically with the reversal of the Dobbs case, we now see reproductive rules that are unique for specific states that are different state to state. So if you have rules specific to protections for reproductive health records, you need to apply those in this process. Some are just reproductive, some are gender affirming. So as those rules apply within your state, you would have to apply that component. Now, many people said, oh, if it's just infeasible, that'll be the easiest exception to apply. And I take exception with that because the infeasibility, there are many components of that you would have to apply. You have to meet each one of those. And feasibility might be such as you've just had a hurricane, or you've had something that shut down your connectivity for someone, but that's infeasible at that moment. It's not going to be you're not going to be shut down with no electricity forever. So if the infeasibility is at that moment, how do you go back and then bring it back so that you have access for the patient? And then the content and manner exception. It's pretty clear. If the patient says, I want the information, the content, and I want it in this manner, and you just simply don't have the means to provide it in that, that's when you have the discussion with the patient regarding the content and manner in which they would accept the information. It may be a twofold process. You may be able to have some go electronically and some may have to be paper. It depends on what they have asked for. Because remember, in the information interoperability rule, you did not have to go back and recreate all of the information that you have to be electronic. You will still have some that may exist in other formats that you will have to connect to, as well as we know that many electronic records, many of the source systems only provide a summary to the electronic health record. And if they're asking for the complete detail of a specific exam that is electronically in another system, you have to be able to connect to or download from that process. Let's move to the next slide.
And one other quick question, Rita, or quick thing. So we've seen quite a bit of abuse of the preventing harm within the EHRs, as far as physicians and clinicians saying you can't access this to prevent harm, it'll make harm or something. And what we're seeing is organizations having to put teams together to train the docs not to abuse that, because you can get into information blocking if you inappropriately apply that or don't take it off when, at some point. So to Rita's point, you're going to have to be very specific in who uses preventing harm, when and how that comes in, how does it come off. Just seems like an area that's gotten hot in compliance. And it's got a lot to do with what the EHR vendors allow them to flag or how they allow them clinicians to flag.
Yeah, very much so, Kelly. And remember, the clinician is really any author that's entering information into that health record. And where I'm seeing, you know, through the customers and relations that I have, that I'm seeing a lot of social work exceptions being applied. And so what's happening there is it's blocking that information, and so they've had to go back and just say that's going to be blocked for 5 days. If not, it has to be reviewed. And they, as Kelly said, special committees are being formed to do that. So let's go. I think we just skipped ahead.
I skipped one just because
Perfect.
of time, and I think it's just summed up what we just said. So
okay, and then this is an example of a privacy exception of documentation, because you're going to have your exception name, the objective of the exception, or basically the rule itself you would have listed, and then reasonable and necessary practices. And then as you go through the exception, you've got to meet the definition defined in it. This says must meet at least one. I would encourage you to meet as many as possible and document accordingly. So this is going to be one of those things that your documentation of your notes as they are occurring must be maintained well. So I would encourage you to think ahead from a standpoint, is this going to be maintained by your privacy officer, by your compliance officer? Are you going to have an information blocking project manager that's going to document who's going to be the go-to person for this documentation as it occurred, so that if you are challenged, you can go back and say, we had this discussion on September the 14th, and now you're being reviewed December of 2025. Can you go back and find that documentation? As Kelly indicated, the information should be maintained for 6 years at this point, because that's the only reference we have to go on. But you need to have extemporaneous notes that you can connect the dots if challenged and justify why your decision was made. And that's going to be crucial. So I will give you an example. For when I first started in privacy many, many years ago, I got challenged because I pulled out my notes and I had a Post-it note on it. And I was challenged that, when did you put that Post-it note on there? So the notes need to be maintained so they cannot be challenged. So think in terms of as if you were going to present this for evaluation for court or for some decision making. Kelly, you want to add to that?
yeah, just that if you want to see that automated, I've got ways of automating this. So happy to show you if you just let me know. But yes, the contemporaneous type documentation is absolutely necessary, and you have to say which of these conditions do you meet. You have to have supporting documentation for it. Like Rita said, you know, you want as much as you can to support it, and each of the 8 exceptions has different conditions. One of them has to meet 2 different conditions, if and then type thing. So it is can be complicated, which is why we automate to the extent that we could.
And I would encourage, as you're putting all this together in your head, suggest maybe either an on-site visit from Kelly, or maybe even to your local HIM group or your state group for a focused discussion on this, where yes, Kelly and I could join you and help you go through some examples. Yes. And we actually put pen to paper and say, okay, here's the issue. How do you document it? And then let's see how the different groups respond to that, because even to determine which exception that you might want to use, or do you apply many exceptions if they occur? So that is going to be the question of the day. Patient access requests are still the #1 issue for everyone if they're saying they're denied access, and that would be whether they're denied access to obtaining a copy or an electronic, or or if it's an electronic access where they want access to that information. So patient access requests will remain the focus here, and you will have to apply those blocking rules as we discussed, whether it's a privacy exception or if it's a cause of harm. You have to be able to validate that and have that documentation available should that be challenged. If you are going to deny access, follow the rules for the denial letters. They're very much the same as they are for any privacy denial. You want to send that and then give the patient the right to appeal it and have the appeal process clearly defined. So the same process would exist there as well.
Yeah, so that kind of what Rita's saying is you already have to do certain things if you're denying access under a patient access rule. There's certain denials that may have to be issued and things like that. You would just also have to say, well, your information, we also invoked an information blocking exception, could be privacy or harm, any of them, but privacy is particularly useful for this because condition 3 is denial of an individual's request for EHI consistent with the individual right of access under HIPAA. So it's trying to be aligned as much as possible that, hey, you're going to deny under HIPAA some access, then you also can tack on, well, as far as information blocking, our exception is, but how much of that you're telling the patient, which exception you invoked and things, there's no standard for that. We don't know the practices yet. Different places are educating the customers differently, but at the end, you have to provide the patient with reasons why you're blocking under HIPAA and under the Cures Act. Let me see. So just a few more things. I know we want to get done in time for a few questions, but you've got to figure out for compliance when, what, and how to provide denial of access or disclosure to any requester group. So make sure you're looking through all your requester types and deciding what information blocking might also apply, not only HIPAA. We think you very much have to data map and catalog all of your data that enters your organization. How does it come in? How does it leave? Or include your FHIR APIs, which are Cures Act, your patient portal, which is more patient access and less Cures Act, although the portal can be used, they are different. And we will have more material on those kind of subjects, but for now, data map the information, how patient information gets in your facility. Sure, you can enter it in the EHR, but you have other information flowing in through HIE connections, whatever. Plus, here's another point on that I heard. Just because you can get information from another site doesn't mean you want it. Doesn't mean you're going to put it into your record and make it a part of your own. So you have to understand very clearly what your configuration parameters are, especially on the largest EHR vendor in the nation. Just make sure that because information is available from other sites doesn't mean it's necessarily sent into your records on a routine basis. You have to figure that out and decide what you want to do. But do your cataloging. Data in, how do your requests go out? How are we going to apply information blocking? Have you done your designated record set? The entire rule is foundational on designated record set. What of the data classes you're going to share are discrete data and what can't be discrete? So are they in a PDF? Do you even have to? The Cures Act doesn't ever mandate paper, but that still the request made in the way that you operate, you may have to give them some parts of the record in paper. So there is a lot to understand in what you need to do for the Cures Act. Again, I think I've said most of this, but update your policies and procedures. Make sure you're talking about information blocking and exceptions in your notice of privacy practices, even though that's not required by HIPAA. You know, decide whether you're going to tell a patient you've invoked information blocking exception, things like that all needs to be done in advance. And, you know, really formalize your planning with your stakeholders in the organization. This is from a grander scope. Address your current state, look for ways to minimize your risk under the information blocking rules. Look for gaps in the law and your best practices. What do you need to do to get there? It'll take a while. Your peers are only going to be able to help so much, but you do want to be talking to your peers about what they're doing for the Cures Act. Give yourself a roadmap for the project. Make sure you have a remediation plan or a plan of action. And then we encourage you to help lead the efforts in the change, because we have seen instances of others not necessarily wanting to pick up the mantle to be responsible. But many of you on this call will probably need to be the leaders on that project. We have a Cures Act checklist we're happy to share with you. Upon request, just ask us for it. We have very sophisticated, detailed assessments of your progress and things like that. We can also use and provide either the templates or the services as well. We appreciate it, of course, you reaching out to us, and did want to show you that there were the portals listed here and the final rule that just came out from OIG. It's 120 pages long. I don't think you have to read it all, but you do need to understand if, as part of HIE, HIN, or sharing EHRs, you get these civil monetary penalties applied. So that is it for the slides. Can we go, reach out to me. I can get any, obviously, communications over to Rita. Let's see what we might have. Alex, did we end up with any questions? Yes.
Yes, there were two questions. The first one was from Rose. She said, are medical billing companies required to comply with the information blocking rules?
It's a good question, Rose. I do not know completely the answer there. On the payer side of the equation, they start to fall into CMS rules. Billing companies aren't payers, but my guess is they do.
That would be mine as well, Kelly, because the intent is for the exchange both ways, for payers to also provide information back to providers. So I would think that there would be some connection there.
And payers and billing companies are going to be able to go get with FHIR interface
Exactly
that they want out of the records through the FHIR and the API access. So I think very much so they do. Let's see.
Another question we got prior to the session was from Jamie, who said, I'm hearing many organizations having issues with providers trying to use the preventing harm exception to protect notes in cases where it may not truly meet the standard. Jamie continued on with some more examples around this, but is it appropriate in this discussion to kind of talk about that?
Yes, and we did some, but let's go there a little bit more. The preventing harm exception is, and I'm going to let Rita kind of expand on it, but first and foremost, a lot of that is generated from the EHR, that the clinicians, as Rita would say, pretty much anyone that can enter notes can block, if their configurations are set so in the EHR, can block access to notes or specific pieces of the record because they say there will be harm. The problem with that is that under the law, to invoke the preventing harm exception, you have to meet the conditions, and they're fairly stringent. So we are seeing an uptick in compliance folks having to educate the clinicians on when and when not to invoke preventing harm blocking from the EHR, because it's hard for the record custodians and managers and release information to understand what to do if those flags are set that you're trying to prevent harm from disclosing this information. But, you know, it is also becoming prevalent and a problem in the industry. So they're being overused. So again, I think it's about education on the proper use. Maybe take a look at the preventing harm exception and its conditions. And we'll do some content with more on that in the future here. But yeah, we can look up, or I can send it to you, the conditions for preventing harm information blocking exception to be used. You kind of back with that and go educate the clinicians not to overuse that function if you can. And we've also seen compliance setting up monitoring teams to monitor the use of those tools, because the clinicians were just going crazy with the flags and saying it's got a risk of harm, so we can't release it. Well, that's going to be information blocking if it's not really well documented and a good reason. So Rita, can you add any?
Yes, a lot of the facilities that I've talked to tried to set up those teams, and it was more than they could handle because there were exceptions being used, you know, preventing harm exceptions totally being abused. So they set up the fact that it would only be held for 5 days to the portal, and that if they had, then they educated those that were using those to say, if you feel it needs to extend beyond that, you must contact us, put the ownership back on them. Otherwise, it was going to be an automatic release.
That's great. That's a great idea. I think that's exactly right. You know, we are the record managers and have to deal with the release of the information externally. You can't just make notes and block them all and then, you know, let HIM or whoever deal with it. It's really sounds like a team effort, and that I like something like that, to where there's a list made of these exceptions or these, you know, flags being set within the EHR, but they're only good for a certain period of time. And to get a permanent one permanently applied, you have to make sure the correct documentation's in place.
Correct. And the other thing too is that those exceptions are set for the patient to receive that information. So realizing that if the patient has signed an authorization for someone else, those exceptions would not be applicable. And I've had a lot of confusion being, you know, asked, well, there's an exception on here. Well, that's not applicable for the release of that information if there is an authorization signed by the patient. So I think people have got to learn to marry the two worlds and how to be compliant in both.
That's absolutely right. You have to marry HIPAA and the information blocking rules together, and the interoperability goes in there too. But yes, and so I would say we're right at the top of the hour, and any other questions that you would like to send in, we can answer via email and get them out to all the attendees. But thank you so much for your time. And Rita, my hat's off to you as always.
Thank you for inviting me.
I think we're going to have to just do some more because there's so much more to do. Thank you, everyone.
Thank you.